This is Rory Spiegel and Ryan Radecki, and this is the Annals of Emergency Medicine podcast, June 2025. Ryan, how you doing?
Yeah, doing great down here, Rory. How about you?
Well, we're getting ready for our military parade here in Washington, D.C., and so, all things are wonderful.
You're not feeling extra patriotic this year?
No. It's tanks rolling down the promenade is not my idea of patriotic. Well, let's move on before we get too into this. I think this is the annual edition where we talk about how happy emergency physicians are at doing their job. So it's a pretty uplifting edition of Annals of Emergency Medicine.
It's a little bit of this, a little bit of that. The first article we'll talk about from this issue is called Where Are They Now? Attrition Rates of Emergency Medicine Residency Graduates by Gender. The lead author here is Nikita Salker, and they are at Maimonides Medical Center. And this is, as Rory mentioned, the first of a couple emergency medicine workforce articles from this issue. And this first question asked is, how many of us are left? And by us, the authors define it as folks who graduated residency before 2010. And by left, the authors define it as clearly established as having an ongoing clinical practice. The question is ostensibly to see if there is a difference between those of binary gender, male or female. And the answer these authors found is basically no. Of all the emergency physicians that they identified in their little search, 5.3% of men had left the specialty, as compared to 5.8% of women. However, this is, of course, an imprecise approximation. When trying to build their cohort for this analysis, they simply emailed a whole bunch of residency programs asking for lists of graduates and received responses from 21 of the 120 allopathic programs out there. Then, to determine whether a clinician was still active, well, they basically just Googled them and checked social media and looked at licensing websites. So not a systematic or a rigorous review. And as you'll hear in subsequent articles on this podcast, this is definitely its own unique thing. Proportionally, they could not find more women than men, probably a result of changing last names. So there could be a difference in attrition from this missing data. Then this is simply, is it likely this person is still practicing medicine? Without any consideration of the annual hours worked or other part-time factors affecting genders differentially. So, as with much population-based research, some substantial limitations affecting the accuracy and precision of their findings.
Yeah, I agree. Surprisingly, the numbers are fairly similar in like general attrition rates to other more methodologically rigorous answers to this question. But you're right. If we're trying to look at the granularity between men and women, you need a far more rigorous way of identifying clinicians than this.
They literally just Googled them. It's tried to find them. Well, are they still there? Are they still alive? They're still practicing? And it is what it is.
All right, well, let's move on to the next one. Staying on the topic of attrition, our next one is workforce attrition among emergency medicine non-physician practitioners. I'm sure we're all aware that there's a growing number of NPs and APPs and PAs that are playing roles in emergency medicine. And this article wanted to look at what were the attrition rates of these providers, not just the doctors. And so they essentially did a repeated cross-sectional analysis using Medicare data from 2014 to 2021. And then they took the Medicare data on provider practice and specialty, and then provider utilization and payment data to find out if they were still billing. And they included NPs and physician assistants who billed independently for greater than 25 emergency services per year. Key variables they looked at were gender, clinician type, practice setting, urban versus rural. And the primary outcome was defined as the permanent exit from emergency medicine practice, and they defined this by no subsequent EM billing over a following year after they were billing for EM services. They looked at age of attrition, stratified by gender and clinician type, and rural versus urban. So what they found was emergency medicine MPPs increased from 2014 to 2021. Most of them were PAs at 65%, 34.8% were NPs, and 64.1% were women, and about 15% practice in rural areas. Attrition rates were high, certainly higher than the last study we talked about. The overall mean annual attrition rate was 13.8. This increased from 12.1% in 2014 up to 17.6% in 2019. They found it was higher in women than men, so 14.7 versus 11.8, higher in NPs at 15.9 than PAs in 12.6, and higher in rural clinicians at 15.1 versus urban at 13.1. They found that women attrition rates occurred earlier with about 40 years versus 45 for men. So all in all, I think methodologically more rigorous than the last study. Again, this is very blunt data. There's not much granularity here. It's hard to really figure out anything more than these really blunt questions. And so, what to do with this data more than know that not everyone who goes into emergency medicine stays in emergency medicine? It's hard to really say.
Yeah, I mean, they make a little bit of a hay out of like, oh, it's the rate is increasing. Well, it's basically stable from 2014 to 2017-ish, 2018-ish. There was a big jump up in 2019 from their data at the very end. So, like, what's the trend going to be over the next 5 to 6 years? Guessing with the pandemic, the trend is bad as far as attrition goes. But this is it's kind of a window into what does the workforce look like when you actually can leave the workforce. Because these are nurse practitioners, physician assistants. They can go work in an outpatient clinic. They can go become a nephrologist. They can go become an orthopedist. Just like I want a new job. Whereas we are kind of trapped, relatively speaking, in our specialty, and we cannot just go. It's a bigger jump to either retrain in a fellowship or to open up a boutique practice and leave the emergency medicine world behind. So it's interesting. I don't know how this compares to. It'd be interesting to see how this compares to other specialties, PAs and NPs, and whether they have lower rates of attrition. And again, they'll have to compare over the same time periods and the same sort of stresses and environmental factors. So, what do we do with these data? I don't know, but obviously, working with people who have more experience in the field and like their jobs is going to make it a better work environment for us as well. Yeah, cruising through. The next article we'll talk about from this issue, and it's clinical practice patterns of the emergency physician workforce before and after attrition. Our lead author here is Doreen Agbo, and they're at Yale University. And this is a little bit different than those prior articles. This one looks at the attrition period itself, sort of like a pre and perimenopausal sort of analysis. Looking at that inevitable transition away from emergency medicine. And just like that last article, as opposed to the first article, these authors used that same sort of Medicare billing data as their indicator of ongoing emergency medicine practice. And they were able to track 60,000 emergency physicians who billed Medicare for more than 50 emergency medicine services. And they found that approximately 3 to 6% of those had a sort of a rate of annual attrition during their study period. And that is to say, physicians who went from billing Medicare for emergency medicine services to no longer doing so. And yes, they were able to sort of see a difference. Generally speaking, those who had attrition from the emergency medicine workforce were starting from a little bit of a lower baseline level of emergency medicine service volume, and their billing tailed off a little bit more than emergency physicians with ongoing practice. The difference was technically real, but it's relatively small. And that indicated to the authors that emergency physicians planning on leaving practice actually do so relatively abruptly and not in an easily predictive way, at least not using these data. As best as they could identify, about 75% of those who left emergency medicine stopped billing Medicare entirely. The remaining quarter had small fractions of ongoing billing in another sort of area of medicine, like a nursing home, or they had some inpatient services or an outpatient department, urgent care, or some other office-based medicine. So it's just another sort of way to look at emergency medicine attrition, and again, limited by the data source. These data don't show age, gender, specific practice setting, or any other descriptive statistics. So they're several steps removed from anything actionable or targeted. And finally, as you can probably guess, it's also missing the characterization of a few people, like me. To this data set, it doesn't look like I'm practicing in any setting. And it will probably be interesting to see what methods can appropriately capture any physician diaspora to, say, Canada or overseas in the past or coming years.
You're saying as our healthcare system is crumbling around us, as we try to flee to more idealistic settings, it just looks like
So
you got up and quit.
I'm not billing
medicine.
Medicare anymore, but I haven't left the specialty. But I guess I have left emergency medicine practice in the United States.
Some would argue you went somewhere where you could actually practice emergency medicine.
Oh, don't be silly. But Canada's recruiting very heavily. I think British Columbia, Nova Scotia, and Ontario have dramatically reduced the barriers for emergency physicians to come over on their like ABEM certificates. And who knows if the other ones will follow.
Yeah, I mean,
there you go.
every few months, we and my wife talk about whether we should be leaving, but we're still here. All right, let's move on. So our next article is web-based training for first trimester point-of-care ultrasound. So I think the more recent generations of emergency medicine trainees have become more and more familiar with using point-of-care ultrasound in general, also during the first trimester of pregnancy to identify intrauterine pregnancies, to try to rule out the risk of ectopic, so on and so forth. And these authors wanted to see if you could do a web-based training program to basically help emergency physician become more competent in these skills. And so they conducted a prospective multi-center study across 18 US and Canadian academic institutions where they recruited 317 emergency physicians. And they basically had them use this training, a web-based training platform that had 400 real patient ultrasound clips. 200 of them were transabdominal, 200 of them were transvaginal. And each case concluded multiple choice questions, including stuff about gestational location, viability, pathology, so on and so forth. And the participants had to review 60 cases and basically continued until they reached a mastery threshold, which they defined as 90% accuracy, greater than 90% sensitivity, greater than 90% specificity. Overall, out of that 317 participants, 204 completed the 60 cases for analysis. Over that time period, diagnostic accuracy improved from 77.6 to 92.1. 65% of them achieved mastery within 60 to 80 cases. The rest required more. Basically, if you read this article, it's a pretty methodologically intense and rigorous article to show that the more you review images, the better you get at identifying the things that you're trying to identify. I think this is really interesting. I think the big limitation here is it's all web-based, and part of the game with ultrasound is being able to obtain these images yourselves. The whole idea of POCUS is that you can do the ultrasound at the bedside. You don't have to wait for radiology to scan the patient to get the reads back. And so you really have a point of care ultrasound to kind of move people through the system faster. But if you still need someone to obtain these images, obviously you're limited by that step. And so you can imagine that this is part of a training program, but obviously you'll need hands-on training as well.
Yeah, I mean, this gets you ready to do transabdominal or transvaginal ultrasound. I probably would say I mostly do or did transabdominal ultrasound for this sort of application in the emergency department. And then, a lot of case review to give, there's no way to get good at this and make sure you're not missing things and know when you're missing things without a whole lot of auditing processes and case review. But this is a start, and it's pretty clear that they've got people who do this program get better at doing this program. So, but whether it translates to as a good surrogate to their ultimate performance is not clear by this. And then our next article from this issue we'll talk about, just a little brief report. Cannabinoid hyperemesis syndrome is associated with high disease burden, an internet-based study. Lead author here is Andrew Meltzer, and they're from George Washington University. And like I said, this is just a brief research report, probably tying into what we would say is our anecdata regarding cannabinoid hyperemesis syndrome, or CHS. And that there are some folks for whom it is really wrecking their lives. These authors solicited folks affected by CHS across the internet, primarily by posting invitations to their survey on Reddit and Facebook. Amazingly, and without compensation, these authors were able to gather just over 1,000 usable responses, and 85% of them completed the entire online survey. Respondents were actually fairly old, with a mean age of 33, and had many years of regular cannabis use. Nearly all were white, and approximately 2/3 were female, and again, approximately 2/3 never finished college. Most of them reported having used cannabis products for a few years before having the onset of CHS. And the study itself was particularly interested in the burden of CHS on those affected. And the vast majority had emergency department visits, half had been admitted to the hospital, most had undergone multiple tests, CT scans, endoscopies, colonoscopies, and ultrasounds. Those with greater than 10 episodes of CHS had undergone more tests overall. The authors do some additional logistic regression analyses for predictors of CHS from these data, but I don't think these add that much, considering these data are such a non-representative convenience sample recruited from a narrow slice of society. At the least, though, these data do provide a little bit of window into the lives of those affected by CHS.
Yeah, I think that's it. I think it's hard to know exactly, just given the selection bias that the study creates. It's a nice like subjective look at the kind of the burden of disease they have, but outside of that, really know how else it helps us with the management of these patients.
Empathy building episode, perhaps. These people go out and get a lot of tests. They may be quote unquote doing it to themselves, but it's really, really a problematic thing in their lives. If there's some way that we can someday figure out a better support system for them in the emergency department other than droperidol.
Which is fairly effective, but you have to come to the ED, you have to sit through, the indecency of waiting in an emergency department and so.
Well, yeah, and then obviously some people just they get another CT scan every time they come in with abdominal pain, nausea, vomiting. So there is that burden and extra danger and financial cost and so on and so forth.
All right. Our next article is the risk of delayed intubation after presumed opiate overdose in the emergency department, with the lead author Daniel McCabe. Obviously, with our fentanyl and fentanyl analogs on the rise, there are concerns about how long you have to watch someone after an opiate overdose, especially once they've had naloxone antidote, and the fear that the naloxone wear off, the patient will still have an opiate intoxication and will have respiratory depression. And if you send them home early, will have a negative outcome because of that. And so what these authors did is they did a secondary analysis of the toxic fentalog study, prospective multicenter observational study, which went on from September 2020 to May 2024 across multiple sites, emergency departments in the United States. And then they looked at adult patients presenting to the ED with suspected opiate overdose, and they identified this by a documented opiate-related toxicity in the medical record, naloxone administration, and self-reported opioid use leading to the ED visit. They excluded patients 18 years or younger, incarceration, major trauma, missing toxicological data, or patients that were intubated within the first 4 hours of their ED stay, because obviously they wanted to look at patients who had risk of delayed intubation. All the patients had biological samples included as part of their routine care, and they were able to take this and use it for high-resolution mass spectrometry to get some idea of what actual drugs these patients did ingest. They also included clinical data, and their primary outcome was delayed intubation, which they defined as endotracheal intubation greater than 4 hours after ED arrival. So, long story short, delayed intubation was very rare. 9 out of the 1,591 patients, so 0.6%, required a delayed intubation. Most of these patients had some other reason to be intubated. One was having a heart attack. There was multi-polytrauma. There was massive hemoptysis. There was lots of reasons why these patients required intubation that didn't seem to be related to their opiate intoxication. There was one patient who required intubation solely due to respiratory depression from opiate overdose. Though if you look at this patient required multiple doses of naloxone and kept getting more and more somnolent, even despite naloxone dosing, and eventually required an intubation. This obviously was not clinically subtle. This was not a patient who got a dose of naloxone, woke up, was doing great, and then 8 hours later decompensated. No, every time the naloxone wore off, this patient became somnolent again and required more and more naloxone until they required intubation. So I think all in all, this is a really nice study. I think it shows what most of us know, that it's not the length of effect of the opioid itself that you have to be concerned about, but rather the length of effect of the naloxone. And as long as the patient is awake and alert after the naloxone should have worn off, the risk of respiratory decompensation in a delayed fashion is exceedingly rare. Most patients, even if they have a long-acting opioid, once the naloxone wears off, if they are going to decompensate, you will see it early at that point, and where they will require respiratory support then and not later on.
Yeah, it just goes to show that your clinical gestalt is appropriate in this situation. That's great. That's what these observational studies are for. They support what we've been doing. It's not like a randomized controlled trial where certain patients get this or certain patients get Y. It's just looking at our usual practice, which is to not intubate most people, which is great. And the ones that we leave unintubated, they do fine. So it validates what we are basically doing right now as far as keeping our patients safe. And obviously, there are these people who are just totally confounded. They've got, this one, two of them had CPR. One of them actually needed to get didn't have cardiac output, was on BiPAP. It's like they don't really. They could have probably figured out a little bit different exclusions.
Yeah,
before
totally.
in their consort diagram, and then it would have been like 0, or 1. This one guy, it could have excluded people who had been on a naloxone infusion at any time or something like that. They could have, there's lots of ways to tweak these data to make it a 0, but they did the one with 9, which is great because then it gives you these cool little stories about the STEMI.
There's a guy with a STEMI and a lactate of 11, a
Yeah.
subdural hematoma. It's like, I think there's one guy that has intracranial subcutaneous gas present, right?
Yeah.
Like there's some bad stuff happening in this cohort that has nothing to do with the opiates.
It's the people you expect that you're going to have to intubate in the end to some extent, and the people you don't, they're safe to go.
Yeah, I think the big takeaway is, if they received naloxone and you wait an hour or so after and they haven't become more somnolent, the likelihood that they will is exceedingly rare.
Great.
All right. Short and to the point, but some really nice articles in here. I encourage everyone to read them. Well, if nothing more, that wraps us up. This was Rory Spiegel and Ryan Radecki, and this was the Annals of Emergency Medicine podcast.